Today, we are going to discuss the pathology of Wilms tumor, also known as nephroblastoma, which is one of the most important malignant renal tumors seen in children. Wilms tumor is an embryonal tumor of the kidney that typically occurs in early childhood, most commonly between 3 and 4 years of age. It arises from primitive nephrogenic blastemal tissue, meaning it develops from immature embryonic kidney cells that fail to differentiate normally during development. This tumor is highly important in pediatric pathology because it represents one of the classic childhood cancers and demonstrates characteristic gross and microscopic pathological features that are frequently tested in examinations. Understanding the pathology also helps explain the clinical presentation, prognosis, and treatment response of this tumor. Let us first begin with the gross pathology shown in the image. Wilms tumor originates from primitive nephrogenic blastema within the kidney. During fetal development, nephrogenic tissue normally matures into functioning nephrons, but in Wilms tumor, some primitive cells persist and later undergo malignant transformation. Grossly, the tumor usually appears as a large, solitary renal mass that often replaces a major portion of the kidney. The image demonstrates a bulky, fleshy tumor mass that is gray-white to tan in color and multilobulated in appearance. The tumor is generally well circumscribed and surrounded by a pseudocapsule formed by compressed renal tissue and fibrous tissue. Despite this pseudocapsule, the tumor can invade adjacent structures and spread if untreated. On cut section, Wilms tumor commonly shows areas of hemorrhage, necrosis, and cystic degeneration. Central necrosis occurs because rapidly growing tumor tissue outgrows its blood supply. Cystic degeneration may develop due to tissue breakdown and fluid accumulation. Residual normal kidney tissue may still be visible at the periphery, especially in earlier stages. Another important feature highlighted in the image is renal vein invasion. Although venous invasion is less common compared to renal cell carcinoma in adults, Wilms tumor can still extend into the renal vein and occasionally even into the inferior vena cava. This is clinically important because vascular invasion may influence staging and surgical management. Now moving toward the clinical presentation, children with Wilms tumor most commonly present with a large painless abdominal mass noticed by parents during bathing or dressing the child. The abdominal swelling is usually smooth, firm, and unilateral. Unlike neuroblastoma, which often crosses the midline, Wilms tumor generally remains confined to one side initially. Some children may develop abdominal pain, hematuria, fever, or hypertension. Hypertension occurs because the tumor may produce renin or compress renal vasculature, activating the renin-angiotensin system. Hematuria may occur due to tumor invasion into collecting systems. The median age of presentation is usually around 3 to 4 years, making it a classic pediatric renal malignancy. Now let us focus on the microscopic pathology, which is the hallmark feature of Wilms tumor. The classic histological appearance is called a triphasic pattern because the tumor contains 3 different cellular components: blastemal, epithelial, and stromal elements. This triphasic combination is highly characteristic and represents the attempt of primitive renal tissue to differentiate into different kidney structures. However, not all tumors show all 3 components equally, and some may appear biphasic or monophasic depending on the predominant element. The first component is the blastemal component, which consists of small primitive blue cells with scant cytoplasm and hyperchromatic nuclei. These cells resemble embryonic renal precursor cells and are usually densely packed in sheets or nests. Blastemal cells are highly proliferative and often show increased mitotic activity, indicating active tumor growth. In histology slides stained with hematoxylin and eosin, these cells appear dark blue because of their high nuclear content. The second component is the epithelial component. These cells attempt to form immature renal tubules and primitive glomerular structures. In the image, we can see primitive tubules and abortive glomeruli representing incomplete differentiation toward mature nephron structures. This epithelial differentiation is one of the features that helps distinguish Wilms tumor from other small round blue cell tumors of childhood. The third component is the stromal component, which consists of primitive mesenchymal tissue. Stromal cells may appear spindle-shaped or fibroblast-like and can sometimes differentiate into skeletal muscle, cartilage, bone, or fat tissue. In some tumors, stromal differentiation becomes very prominent, producing heterologous tissue elements. This diversity of tissue differentiation reflects the embryonal origin of the tumor from multipotential nephrogenic cells. Another very important concept highlighted in the image is histologic variance and prognostic significance. The classic triphasic variant is generally considered the typical form. Some tumors are blastemal predominant, while others may be epithelial predominant. However, the most critical pathological feature influencing prognosis is anaplasia. Unfavorable histology with diffuse anaplasia is associated with poorer outcomes and resistance to chemotherapy. Anaplastic cells show enlarged bizarre hyperchromatic nuclei and abnormal mitotic figures. The presence of diffuse anaplasia indicates aggressive tumor biology and is considered one of the most important adverse prognostic factors in Wilms tumor pathology. The image also emphasizes prognostic factors beyond histology. Tumor stage is extremely important. Localized tumors confined to the kidney generally have an excellent prognosis with modern therapy, whereas tumors with vascular invasion, lymph node involvement, or distant metastasis have more advanced staging. Patient age also influences prognosis, with younger children generally responding better to treatment. Fortunately, Wilms tumor overall has a very favorable outcome compared to many pediatric malignancies because it responds well to surgery, chemotherapy, and radiotherapy when detected early. From a pathological perspective, Wilms tumor is an excellent example of an embryonal malignancy arising from primitive tissue remnants. The triphasic pattern reflects abnormal recapitulation of renal embryogenesis, where immature cells attempt incomplete differentiation into epithelial, stromal, and blastemal structures. This unique histological appearance makes Wilms tumor one of the most recognizable pediatric tumors under the microscope. To summarize, Wilms tumor, or nephroblastoma, is a malignant embryonal kidney tumor arising from primitive nephrogenic blastema in young children. Grossly, it appears as a large, fleshy, well-circumscribed renal mass with hemorrhage, necrosis, and cystic degeneration. Microscopically, the classic triphasic pattern includes blastemal cells, epithelial differentiation forming primitive tubules and glomeruli, and stromal mesenchymal elements. Clinical presentation commonly includes a painless abdominal mass, hematuria, abdominal pain, and hypertension. The most important prognostic factor is histology, especially the presence or absence of diffuse anaplasia. Early diagnosis and modern multimodal treatment have significantly improved survival, making Wilms tumor one of the success stories in pediatric oncology.